Everyone. This week we're learning all about the embryology of the orofacial structures, and by this point you should have developed a basic understanding of the content for the week. In today's lecture we're going to dive into the why behind the embryology fundamentals you've been studying. So if you haven't done your studying, you might be a little bit lost at some points during our lecture today. But you guys are going to deal with embryology every day in your practice as a hygienist. So our lecture today is the fun part of what you've been learning. You guys are going to really want to pay attention to the lecture because you're going to see some of this information on your module exam and on that practical exam that we said we weren't going to talk about. And you'll probably see some of this stuff on your national board as well, which I know you're not worried about just yet, but you will be before you know it. By Thursday of this week, you should have a really good understanding of our material. So when you show up to lab, you want to make sure that you really have a good fundamental understanding. But our lab is structured to enhance and solidify that knowledge. And if you wait until Thursday to try to understand the content, you're going to be somewhat lost and you really won't gain as much from those interactions. Now, before we dive into the grit of our lecture, we're going to first view a video that really puts all of this into perspective. And I want you to watch very carefully in the video and try to put what you've been reading in the textbook and studying in your PowerPoints into action with the fetal development. And I'm going to put some little pointers in the video as well, so make sure you're watching it very carefully. You should be able to recognize some of these structures forming, but really this video is just incredible. Every time I watch it, I just get chills. It never gets old. So here we go. Wow, what an incredible demonstration of embryology, guys. Hope you enjoyed that video as much as I always do. So what do you think about this? Congenital malformations, can they be traced to a specific time period? Well, hopefully you would say yes. That is why embryonic period is considered the most critical time, because there's so many things that can go wrong. Okay, so the conditions we're going to talk about today all happen within a certain period of time in the tooth development. So it is important for you to know the different stages of tooth development and what happens in each stage, because all of these conditions can be traced back to a certain time period in tooth development. So before you move forward, pause the video and review the stages of tooth development. The first condition we're going to talk about is anodontia. As we work through these developmental disturbances, we're going to work through the tooth development process as well. For instance, the first disturbance is anodontia, which occurs in the initiation or the first stage of tooth development. As you move through the information, feel free to pause the video if I go too fast so you can get all of your blanks filled in on your PowerPoint. I already mentioned that anodontia happens during the initiation stage of tooth development. But what is anodontia? Essentially, it's a missing tooth. So if you think of it in that way, the tooth never did initiate, so it has to be a condition of the first stage of tooth development. Now, this is different from someone who has had a tooth extracted. That would be quite different. We're talking about congenital missing teeth. Sometimes there are other factors, but the most common would be hereditary. Why is this important to know? Well, it can cause a lot of issues for our patients, cosmetically and functionally. We'll talk more about that on the next slide. So here we have an example of anodontia. In this photo, the patient is missing number 7 and number 10, or also called the maxillary lateral incisors. This is very significant not only cosmetically, but functionally as well. Consider the cost of replacement of these two missing teeth. It can be a significant burden. Socially, this would be highly disruptive to the patient's ability to interact with others, and often causes them to fail at gaining employment. Functionally, the patient may develop a lisp or a malfunction of the tongue muscles in trying to overcome that additional airspace. So anodontia is an important developmental disturbance for our patients. As hygienists, your patient will ask you about the cause of this condition and the options of fixing it. So you need to have an intelligent conversation with them on the topic. And you'll gain a lot more experience with that clinically once you start to see patients. Here we have another example of anodontia. Unless you have a background in dentistry, you might have a hard time here. In this x-ray, we can see there are teeth in many different stages of tooth development. This is probably my favorite x-ray to have because it's so fascinating to see the teeth in such different stages. Our little patients really like this as well. But what we can see is that most of the permanent teeth are in the apposition and maturation stages of tooth development. I know that because I can see that the teeth are depositing enamel and have completed, some of them have completed the deposition of enamel, and some are now forming root structures. There are some teeth, though, that have not begun tooth development at all. For instance, the third molars are not visible in this film because the patient is only 9 years old. One thing interesting about this pano is that we can see the patient is missing a permanent tooth. If you look on the patient's lower right side, you can see that there are 2 premolars forming below the primary molars. And on the patient's left side, there's only 1 premolar forming. She's congenitally missing number 20. This became significant for this patient as she began ortho because the orthodontist was able to plan around the missing tooth and pull the other teeth closer in to fill that gap. And I know this because it happens to be my precious daughter's Pano. She's 13 years old now and finally lost all of those primary teeth. So anodontia is an important anomaly with multifaceted resulting issues that we sometimes need to address. Some of you may even have anodontia because it's actually quite common. Okay, supernumerary teeth. We can break down the word of our next developmental disturbance to find the meaning. Super means extra. Numerary means numbers, and then teeth. So we have extra numbers of teeth. Again, this happens in the initiation stage of tooth development. We can't have an extra tooth if there never was one there to form. These are also mostly hereditary, as are most of the conditions we're going to talk about today. But there's a particular type of supernumerary tooth that is found between the tooth front teeth called a mesiodens. That tooth, which we'll look at in just a second, can cause many issues, but when found early can be removed without causing significant harm to the development of the maxillary alveolar bone. One reason why panoramic x-rays are taken when a child reaches age 6 or 7 is because we can catch some of these developmental anomalies before they cause any permanent harm, and we can also often intervene and save the parents a lot more money. We also tend to see supernumerary teeth behind the wisdom teeth, or as I would say in dental speak, distal to the third molars. This can cause issues with crowding and disrupt proper occlusion. So again, routine preventive screening can catch these issues so we can deal with them promptly. Here we have an example of a mesiodens. There's an extra tooth between the maxillary central incisors, or two front teeth, which has significantly displaced those incisors from their normal position. Had this tooth been found early on, it could have been removed without causing this issue. Here is another example. You can see how this tooth is conical shaped. That's pretty typical of a mesiodens. They tend to be smaller and peg in appearance. Here's an example of an x-ray of a child who I would presume is about 5 years old. These are the primary central incisors, and these are the permanent central incisors that are still forming. So you can see here between the two incisors is a mesiodens. Thankfully, they found this on x-ray at such a young age that they'll be able to remove it, and the residual space will actually fill in with bone on its own. The patient probably won't see any long-term effects from this anomaly. This is pretty cool. This is a cone beam CT scan. Again, these are the maxillary central incisors, and here is our mesiodens. Okay, now this is pretty obviously photocropped, but I thought it was pretty funny. Can you imagine? I mean, good grief, that would be a nightmare. Trying to keep all that clean. I mean, it's not even really that great of a Photoshop job, but it's cool nonetheless. This, however, is not a photocrop. So this was taken from a patient in our clinic. At first glance, or to the untrained eye, it could appear that the patient just has some crowding of the lower teeth. But once you're done with this course, you should be able to easily identify these as supernumerary teeth and to be able to identify them in clinic. So how do I know that? Well, the normal dentition are all present. Each adult has 2 premolar teeth, and this patient clearly has 3 premolar teeth on each side. This is a congenital abnormality that I've seen before, exactly like this, which is kind of strange, but I have seen exactly this situation before. The best case scenario for this patient would probably be to remove the supernumerary premolars and help them try to maintain good oral hygiene, because otherwise the risk of gum infection is significantly higher for this individual and decay. This patient was referred to a local oral surgeon for an evaluation. Okay, this one is also not photoshopped. The patient has a condition called hyperdontia, which is essentially a whole bunch of supernumerary teeth. So we have an intraoral photo of the teeth, and this is a cast model of the patient's mouth. This would be quite a complicated situation to remedy, but one that really needs to be addressed, or infection probably certain. Okay, now I know you guys aren't all familiar with reading radiographs. I don't expect you to be able to do that very much, but you will have a radiology class this next semester in the fall with our infamous Julie Metlin. She is a radiology guru, and she's going to teach you everything you need to know in order to be successful in radiology in the clinic and in practice. But we're going to discuss some very fundamental issues in this class. Here we have two panoramic x-rays. And I want to give you just a minute to see if you can spot the anomaly. Okay, these are actually panos taken from twin sisters. In the first pano, there's a supernumerary premolar sitting right between the fully erupted premolars. In the second pano, the patient has the same exact anomaly, but on the opposite side. So how cool is that? And something you're going to learn in dentistry is that twins typically do have the same issues, but on opposite sides. So that's a pretty good example for you guys. Again, with our next anomaly, we can break down the roots of these words and find its meaning. So micro means small, dontia means teeth, so microdontia means small teeth. Likewise, macro means large, dontia means teeth, so macrodontia means big teeth. We're going to be moving now into the bud stage of tooth development. We can see a common theme here, as many of these conditions do have a hereditary component. That's also true of micro and macrodontia. Most of the time, this anomaly affects a limited number of teeth, but if all of the teeth are affected, there's probably a systemic issue at play. Microdontia in the form of peg laterals is something you're going to see quite often compared to other anomalies. I can't promise that each one of you are going to see a peg lateral in the clinic, but it's so common that there's a high likelihood that some of you will see that while you're here with us. But peg laterals affect the maxillary lateral incisors, and peg teeth also happen with third molars, or microdontia happen with third molar teeth, also known as wisdom teeth. Here we have a maxillary lateral incisor that is affected by microdontia. We typically refer to these as peg laterals in practice. In the clinic, you would hear me call them peg laterals. It gets its name from the way a pirate's leg looks. So somewhere, a pirate's peg leg, you know, when they have a fake leg. But somewhere along the way, people started calling them peg teeth, and the name just kind of stuck. So it's not really scientific there. But this picture is also of a patient that was in our clinic. So here we have a front picture. So this is from the lip side. And here we have a back picture, which is from the tongue side or the lingual side of the tooth. So these teeth often become a cosmetic concern. So it's not unusual for a patient to spend quite a bit of money to put veneers or crowns on these teeth to build them up and make them appear more normal in appearance. Here we have a bite wing x-ray and a tooth that is very small in size. This is actually tooth number 1, or the maxillary right third molar. This is a wisdom tooth in the upper right, which has microdontia. And this happens quite a bit with third molars. Here we have a before and after. This is a case where all of the teeth were underdeveloped, so it was more likely to have been caused by a systemic or endocrine issue. The after photo demonstrates how cosmetic work can be done to enhance the appearance of teeth and give a more mature look. So this patient spent a lot of money to make her teeth appear more normal in size. Here is a case of macrodontia, in which the maxillary right central incisor is abnormally large compared to the other teeth. So since all the other teeth are normal in size and appearance, this is probably a hereditary issue. Okay, not my baby. Just a stock photo, but so cute. I couldn't resist. Dens and dentae is a very interesting phenomenon. Essentially, this phrase means tooth within a tooth. How weird was that? I mean, I grew up on a farm with chickens, and never in my life have I seen that occur. All I can think is that poor chicken. Anyways, that's a pretty good demonstration of what we're going to talk about with dens and dentae, which means a tooth inside of a tooth. So this happens during the cap stage of tooth development as proliferation is occurring. The enamel organ will invaginate into the dental papilla and continue to grow, creating a tooth within a tooth. I'll try to give you a visual demonstration of this, though you have to promise not to judge me on my drawing skills. Now, dens and dentae most commonly occurs on the lateral incisors, the maxillary lateral incisors. So I'm going to draw a side view of what a lateral incisor should look like. Again, don't judge. So here is the root, and then this is going to be our crown. So this would be the facial view, and this is going to be our lingual view. So we're actually looking directly at the side of that tooth. And now I'm going to draw what a tooth with dens and dentae looks like. There are some variations of this, but I want to try to give you an example of what that means to invaginate into itself. So we're going to draw the root, and then here is our crown. So when this tooth was forming, a little canal opened up within the tooth. So this part of the tooth has enamel inside the tooth, and there's a direct chamber leading right to where the nerve of the tooth is. So this tooth is extremely susceptible to decay, because even if, let me erase that and show you this. Even if that invagination was more compact, decay, all the bacteria is going to want to really pack down into the groove that you would find on the lingual side of that tooth. So these teeth tend to decay very easily. Hopefully that makes a little bit of sense. But this condition is also hereditary, and like I said, it does affect the maxillary lateral incisors. So when in doubt, have you noticed that a lot of these anomalies happen on the maxillary lateral incisors? So if you don't know the answer to a question and that is an answer, that's a pretty good guess. Here we have an x-ray of a tooth that has dens and dentae. And I want to point out a few things to you on the x-ray to help you see what I see. First of all, enamel is the hardest structure known to man. On an x-ray, the more dense the tissue, the thicker the tissue, the whiter it appears on film. So, for instance, this is black space. It's black because there's only air there. On this x-ray, we can see enamel outlining the tooth. This is going to make more sense to you in week 3, but enamel appears whiter than other structures of the tooth because it is the most dense. And it should only be found on the crown or the outside of the tooth. However, in this x-ray, you can see that there is enamel formation within the tooth itself. And there's a section of the tooth that's left very vulnerable to decay. So if enamel is on the inside of a tooth, it's almost certainly going to be because of dens and dentae. Here are 2 more examples. Try to find the enamel that is within the tooth, and then do the same thing in the other picture. Okay, here is the enamel within the tooth on this picture, and here it is in the other one. So hopefully you were able to identify that. Now this is a really neat find. A dentist brought me this tooth which he had extracted and sectioned for me that shows dens and dentae in real life. So here is the part of the tooth which was invaginated and enamel which has formed inside of the tooth. Pretty cool. Before we dive into the rest of our material, you need to take a break. So hit pause, get up and stretch, go to the bathroom, get a cup of coffee, and then when you come back, hit play again for a quick brain break, a fun little video before we continue.
You ready?
Of course I'm not ready. I don't want to do this.
Any final words, Millicent?
No.
She should not use a straw.
If you aren't ready and ride this out, we'll let you know.
The Center for Disease Control in Washington, D.C. has issued a viral outbreak warning. State and local officials have reported cases of high fever, nausea, death, and even cannibalism. Stay in place until further notice.
What the heck? Did you?
What? I was just driving like a slug to get to the house.
Hold on, Mom's calling. Hey, did you just get that emergency alert? Yes?
You need to get home right now. I got notice in the emergency broadcast system. There's some sort of a weird virus outbreak that is not a test.
Okay, I'm pulling the driveway right now.
We're not the U.S. Marines. I can't wait to start going now.
Okay, there's Barry. He's got the Jeep. Don't move.
What? Like cannibals? What is this, zombies? Police are coming or something and...
Yeah, it's literally all over the news.
Trying to put... Cabot, a garden hoe isn't what we want. We have guns. Why are you putting garden equipment
All right, I'll go get the gun.
in the car?
You're gonna need to defend yourself. I can't be with you the whole time, okay? Look, this is how you use it. Safety's right here. Pull this. Try. I need you to see you do it, okay? You gotta hold it up. If anything comes, hold the weapon. Hold it up. No, hold it up. Hold it up, okay? You got it? Okay, I'll be right back.
What is this supposed to do for me? Give me a knife. How am I supposed to defend myself?
Listen, we can only take one pet. Which pet? The cat or the dog?
The cat! You idiot!
Okay.
No!
What do we do with the dog?
He's the worst! He's already dying! Just leave him!
Okay,
Get
we will.
the
Okay,
cat!
okay. I got the cat.
Please.
Mom said we're leaving the dog.
Okay, that's fine.
Okay. Dad said that since he's in Las Vegas, that he's close to Mexico and he wants us to meet him in Mexico. How good is your Spanish still from high school?
I can say pants.
Millicent, we can only take Funfetti or chocolate cake. Which one do we take? Funfetti? Do you want Funfetti or chocolate?
Why would you
Which? No, Millicent, this is important. This will be what we're living off of. Which one? Funfetti, chocolate. Do you think Costco, should we go to Costco first?
No, it's gonna be a bloodbath in there.
She's probably right. She's probably right. Millicent, what about Mexico?
Why do I have to be understand
Millicent,
this?
what about... Millicent, you know where we're gonna go? We're gonna go back home, and you're gonna get in bed, and you're gonna sleep for the next couple hours, because there's no zombie apocalypse. All right, we're gonna go let you get in bed.
Millicent, I'm sorry.
I'm sorry.
We love you.
We love you. I'm gonna turn this off.
Okay, we're going to go ahead and dive into gemination and fusion. These two are easy to confuse, but you're definitely going to want to know the difference. Gemination also occurs in the cap stage of tooth development when the tooth germ tries to divide but is unsuccessful. And again, this is a hereditary issue. One thing that helps us distinguish gemination is that there's one root, but the twinning is in the crown portion. So the only way to truly distinguish gemination from fusion is to either count the number of teeth in the occlusion or to look at an x-ray. And hopefully I can give you some examples in a minute to help this make more sense. This is an example of gemination from your text, and in my opinion, it's like the worst example ever. So I'm going to show you some better examples in just a bit. But if you were looking at this in your text and thought, this just looks like a tooth with a chip in it, yeah, I think so too. But nevertheless, it's a good lesson from looking at the picture that there are anomalies that are sometimes impossible to identify by looking clinically. But this is also a good example of why x-rays are important to us in dentistry. So here we have an x-ray of a geminated tooth. This is a tooth that tried to divide unsuccessfully. So these are primary teeth, and these two are the mandibular central incisors that are still growing inside the jaw. The geminated tooth is a mandibular lateral incisor, and this one is a canine. So all of the teeth are there. There aren't any extras, but this tooth clinically appears much larger because the tooth crown divided a little bit. So at the top you can see that there's a split in the crown, which we would be able to see clinically, but we still only have one root. So a split crown but one root is gemination. Okay, I know it's a little cruel for me to use a picture of a snake. I'm sorry if you are afraid of snakes. My husband would just die if he knew I used this. But this is a good example because the same thing happened to these snakes that happens with a geminated tooth. So they tried to divide unsuccessfully and they're conjoined at the neck. They have two heads, one body. Just like our geminated tooth, two crowns, one root. Okay, this is my little baby boy. Isn't he so cute? When his primary tooth, this one right here, was beginning to grow in, I noticed that it seemed abnormally large. And at that time, it was one of the first teeth to appear. So I didn't know whether this was just macrodontia or if there was some other anomaly. So I brought him in when he was about 2 years old, and I was able to get an x-ray in that area. And by that time, I pretty much knew that this was a case of gemination because all the teeth were there. So here's the canine and the lateral and the central. And sure enough, I was able to confirm on x-ray that he had a geminated tooth. I couldn't believe it. It was the first time I'd seen a geminated tooth in a patient, and I have seen that since then. But of course, if it's going to happen, it's going to happen to your own kids. So my daughter is missing a tooth, and my son has a geminated tooth. Go figure. Fusion can appear very similar to gemination clinically, but once you learn the differences, you should be able to distinguish fusion from gemination. Like gemination, fusion also occurs during the cap stage of tooth development, but unlike gemination, fusion occurs when two tooth germs encounter some sort of pressure and they end up fusing together. So let me give you a little bit of a visual to help explain this. Let's pretend that these circles are tooth germs. And normally there would be some separation of the tooth germs. So each one's going to develop into a different tooth. But if for some reason there is, let me see if I can get this to go, pressure in the area that pushes them together, then they can end up kind of fusing together, and they fuse at one section, but then they go on and they continue to develop as two individual teeth. They just happen to be conjoined at that one little section where there was pressure. So remember, with gemination, all of the teeth were present, but one appeared abnormally large. With fusion, one tooth would appear to be missing, while one tooth would appear to be very large. Since two tooth germs united, it appears as one large tooth rather than two normal-sized teeth. But note that this is different from macrodontia, which is just an abnormally large tooth. So fused teeth appear large because of a different reason. Here we have an x-ray of the lower anterior. These are primary teeth, and here are the permanent teeth still forming in the jaw. This is a central incisor, and these are the lateral and canines, which have fused together. So if you note, there are two crowns separated with a groove, just like in gemination, but with fusion, there are two roots, there are two pulp chambers, unlike gemination where there's only one root and one pulp chamber. While it can be difficult sometimes to distinguish between fusion and gemination clinically, here I can see that there's a central incisor and one large crown where the lateral and canine are. So if this had been a geminated tooth, there would be a separate lateral and canine, but one of them would appear larger than normal because that tooth germ had tried to divide. Take a look at this x-ray. Based on what you've learned so far, do you believe this is a fusion or a gemination? This is a case of fusion. I can tell that because there are two heads separated by a groove and two distinct roots with two pulp chambers. Here is a quick view of the difference between fusion and gemination. On fusion, we have the union of two adjacent tooth germs. They've had some sort of pressure, so they have a large tooth with two pulp cavities. There would be one fewer teeth indentition. With gemination, the tooth germ has tried to divide, so there's a large single-rooted tooth with one pulp and twinning of the crown. But there's a normal number of teeth indentition. Excuse me. And here's another visual. So here we have fusion. We have a crown that has a groove, large crown with a groove, but two roots. Gemination, one root. Alright, what about this tooth? Is this tooth geminated or fused? There's two heads separated by a groove, but only one root. Therefore, this is a geminated tooth. So this tooth germ tried to divide but was unsuccessful. And what about this one? Again, there are two heads separated by a groove, but only one root and one pulp chamber. So this tooth has been geminated. And one more guess here. This is a case of fusion. There are two heads separated by a groove, but two roots with two pulp chambers. This one is a little bit trickier and super rare. Both of these have two heads separated by a groove, but the right central has two roots and the left central only has one root. So the right one is fused with the canine, with the lateral, and the left one is geminated. Pretty cool. A lot of students have a hard time pronouncing this word, but the correct pronunciation is tubercle. So you put an emphasis on the U, not the E. So it's tubercle, tubercle. And tubercle is a general term meaning protuberance or projection. But in dentistry, when we discuss tubercle, we're meaning a specific condition. Tubercle also occurs during the cap stage of tooth development, and this refers to an extra cusp of enamel on the tooth. When the tooth is forming, if there is pressure or trauma, an extra cusp can develop on the tooth. There are some places where this is considered normal anatomy, such as the lingual of the maxillary anteriors. When it's found on premolars or molar teeth, it is considered an abnormality. I want you to stop and take a minute and feel of the back side of your upper anterior teeth. Do they feel smooth? Do you feel a bump near the gum line? If you have a tubercle in this area, it's called a cingulum, and it's very common and normal. If you don't have a cingulum, that's also considered normal. So if you feel a protuberance near the gum line on the lingual of your upper anterior teeth, you have a cingulum. If you do not have that, then you do not have a cingulum. So it's just a variation of how we're all made. Here is a premolar with an extra cusp. We haven't had tooth anatomy yet, so you may have a harder time recognizing this abnormality. But here we have a first molar, and here is number 4, or the second maxillary premolar. And all posterior teeth should be smooth on the cheek side. So if there's a cusp sticking out, it just doesn't belong. So this tooth is at high risk for decay due to the extra groove on the cheek side of that tooth. Inside of that, by the way, it's not just a solid brick of enamel, because we're going to talk about enamel abnormalities in just a minute. Inside of that cusp is dentin. So this is a formation of tooth process beyond just enamel. There's other tooth structure inside of that. So here is what a cingulum looks like. If you have a cingulum on your anterior teeth, you can feel that bump. This is kind of an exaggerated picture. Most are not this pronounced. Although my husband does have cingulum on, I think, most of his upper maxillary anterior teeth. This one is a crazy large cingulum on the lingual of number 9 in this patient. This can cause significant problems with occlusion, and you can see that this tooth has actually been displaced facially. The tooth is also at high risk of decay because of this abnormality. Okay, next we're going to talk about enamel dysplasia. And enamel dysplasia is a very broad term that encompasses any type of faulty development in enamel. Enamel is formed by cells called amyloblasts. So any interference of these cells can cause faulty formation of enamel. This is really important to remember. If the developmental disturbance involves any type of faulty enamel, then that had to occur during apposition and or maturation of the tooth development. Now you're probably thinking, but Ms. Richardson, you just talked to us about tubercle and how it was an extra cusp with enamel. But that is not faulty enamel. That is a separate developmental issue. With these, we're talking about enamel that did not deposit correctly. So if that occurred, it has to occur during apposition and maturation because enamel doesn't deposit until apposition stage. Some disorders of enamel are hereditary, but most of the time they're going to be local or systemically caused. So they can cause unsightly defects that create some self-confidence issues in our patients and can make the teeth more vulnerable to decay. In this week's discussion board, you had to do some critical thinking in regard to enamel formation. You're frequently going to hear patients say things like, well, I was born with bad enamel, or I didn't have any enamel on my teeth, or my baby stole all the calcium from my enamel when I was pregnant. But 99% of the time, these patients are completely misinformed. But here we have an example of a case of amelogenesis imperfecta. Remember I told you that enamel is formed by cells called ameloblasts. So if we break down this word, we can see that it means imperfect formation of enamel. In 18 years and thousands of patients, I could count on one hand the number of people who I've actually encountered with this condition. It's actually quite rare. Here's another example of amelogenesis imperfecta. Underneath the enamel layer of our teeth is structure called dentin, and the dentin appears very yellow in color, so it's more coarse, it's more porous, it's extremely vulnerable to decay, and you can see that this patient did not form enamel on the teeth, which is why you see the yellow dentin. In the lower anterior, those front teeth have been covered with resin material to give it more of a cosmetic appearance. But what happens with most patients who say, I never had enamel, is that they just have a lot of decay and they're not really ready to own that responsibility. So denial can be quite powerful. I mean, I've had patients that swore to me they had no enamel even as I'm showing them the healthy enamel on their teeth in a picture. So most of the time those patients are just in quite a bit of denial. Here's another type of enamel dysplasia. This patient has enamel covering the teeth. It looks to be pretty solid enamel, but the enamel is extremely pitted and bumpy. So this could be that those ameloblasts did not deposit enamel uniformly throughout the tooth structure. Hutchinson's incisors are another type of enamel dysplasia, particular to the teratogens of syphilis. So a teratogen refers to anything that causes malformation of the embryo. So syphilis can affect the deposition of enamel during tooth formation. Fluorosis is something that we see very frequently in this region. Fluorosis is caused when people ingest too much fluoride. Now, fluorine is a naturally occurring element, and when mixed with another element like calcium or sodium, it becomes a compound fluoride. So like in our toothpaste, we might have calcium fluoride or sodium fluoride. When we use toothpaste and drink water with fluoride, that is a man-made compound created in varying ways. But the fluoride compound can also be found naturally when naturally occurring fluorine combines with other elements in the soil. There's still many parts in the world, and even some folks here in Texas, that still receive their water from a well. And the disadvantage to doing that is that you don't know what level of naturally occurring elements are in some of those areas. And the natural fluorine content and fluoride content is very high in the soil, which then also leaks into the water. So children who drink this well water will ingest too much naturally occurring fluoride and have permanent damage to their teeth due to enamel dysplasia. That's the advantage of having city water, is that they test that water very frequently to make sure that there's nothing in the water that's going to cause permanent damage. The reason that we see that really often in this region is not because of the well water drank in this region. We do have a lot of well water around here, but we don't have a lot of naturally occurring fluoride in our soil. But we do have a lot of immigrants from Mexico who grew up drinking the water from a well. So it's well known that regions of West Texas and Mexico have a high content of fluoride in the soil, thus causing fluorosis. Inevitably, when you see this condition in the clinic, it's almost always going to be on a patient that was raised at least until the age of 10-ish in eastern Mexico or western Texas. Now, I haven't encountered a lot of enamel pearls, but I have seen several over the years. And as a hygienist, it is important for you to be able to identify this, especially when you start treating periodontal patients, which you won't do it until your second year with us. But nevertheless, we're going to go ahead and learn about this condition now. Now, this is still dealing with improper apposition of enamel, so it cannot occur before the apposition stage of tooth development. But the appearance of the enamel pearl is exactly as it suggests. It's a round pearl made of enamel. This happens when like a rogue group of ameloblasts end up on the root surface for some reason of a tooth, and they deposit enamel on the root surface when they shouldn't. And it's really a perfect sphere of enamel. So you can see on this x-ray, there is a perfectly round white area on the tooth of this x-ray. It's almost certainly an enamel pearl because there's no other reason for enamel to be deposited on the root of that tooth. And this is what it would look like clinically. So here you can see right between the roots of those teeth, a nice little enamel pearl. Now, before we review some of the things we learned today, I want to give you the submission for this week's credit for your online lecture. The first thing that I want you to tell me is, do you have a cingulum? Earlier in our lecture, you were supposed to stop and feel and see if you have a cingulum. So tell me, do you have a cingulum or not? The second thing is, tell me what type of cells produce enamel. Cells that produce enamel. So I've mentioned several times in this lecture the type of cells that produce enamel, and that's the second thing I want you to tell me. So don't forget to put your submission on Canvas so you can get credit for watching this lecture today. All right, now on to our review. What condition do you see here? Or what condition do you not see here, I should say? Hopefully you guessed endodontia. Now, even if you're quite familiar with the layout of the teeth, among the conditions that we've learned today, the only feasible one to identify here is endodontia because we can clearly see that there's holes where teeth are missing. And since we're learning about congenital abnormalities, we're going to assume that these are congenitally missing. And we're not talking about extracted teeth. Everything we're talking about in this module are congenital abnormalities. So what do you see in this picture that does not belong? Look between the two front teeth at the conical shaped tooth that has displaced the maxillary incisors. Did you guess mesiodens? Then you are correct. I know this isn't a peg lateral because it's between the two front teeth. Here we can see that there's a normal central incisor, a normal canine, and an abnormally small lateral shaped like a peg. So this one would be a peg lateral. Now remember, you aren't expected to be experts at reading radiographs yet, but this one should be obvious because I can see the dense white enamel inside the tooth structure where it does not belong. It appears as though the tooth has invaginated into itself, so this one has to be. Okay, let's try to identify these disturbances based on just some general characteristics. Our first one has a twinning of the crown, which only has one root. I'll add that in. So twinning of the crown with only one root. And we know that that can only be gemination. So this one has two teeth that have married and become one union. So there's two crowns and two bodies, but they are joined together. And that one would have to be fusion. A tooth that is abnormally large, macrodontia. An extra tooth between 8 and 9, mesiodens. Congenitally missing, anodontia. Abnormally small, microdontia. And extra cusp. That would be a tubercle. What do we see here? We see very yellow pitted teeth that have no enamel. This is a case of amelogenesis imperfecta. And here we have another case of dens and dentae. So see the dense white enamel outlining the tooth? We can see the same density of the enamel inside the tooth where it does not belong. So we don't see enamel inside the tooth, inside this tooth, or inside this one. Hopefully you guys can see the difference in that. Now this you should be able to readily identify as features of a patient with Down syndrome. So make sure that you're familiar with the features of Down syndrome. Okay, a cleft. This little baby has a cleft lip, a unilateral cleft lip. Now, a cleft is caused by failure of fusion of the maxillary process with the medial nasal process. The face forms from the back of the neck forward and from the head down. So when those processes fail to fuse properly, clefting occurs. We are very fortunate in this country that these types of conditions are normally found at birth and corrected shortly after. Sorry about the computer sounds there. This isn't the case in other parts of the world, though. Some clefting is so severe that life is unsustainable, and without surgical intervention, many of the babies will die from that condition. So we are very blessed to live in a country. Even though our healthcare system is a hot mess, we still get the care that we need when we need it. So here we have another condition caused by the teratogens of syphilis. This one we call a mulberry molar because the grooves are severely deformed and resemble a mulberry. A mulberry, sorry about that guys, I don't know why that keeps dinging, but a mulberry molar is caused by a teratogen of syphilis. And here we have our tubercle. Okay, your module test this week is going to consist of 2 essay questions. One of those questions is going to come directly from this lecture. Directly from this lecture. So you now have all of the information you need in order to be successful in this module. You're going to want to study your portfolio contents very well. Something to keep in mind is that not everyone is going to have the same questions on your Module 1 exam. While everybody's going to have the same difficulty level of questions, my exams are set up with test banks. So for instance, you may have 10 questions in the difficult category, but there's a test bank of 20 difficult questions. So you're not all going to get the same difficult questions. So similarly, essay questions are similar, but not identical. So remember, your career. It's no longer good enough to just cram and pass your test. You need to retain the information for long-term success. So happy studying. Please do not hesitate to email me with any questions, and I will see you later this week.